Dal pal. Just 2 minutes left.
Good morning, respected faculty and dear delegates. Today we are going to have an important session on ankylosing spondylitis and other spondyloarthritis by Dr. Narendra Bagri. I request our President, Dr. Pankaj Garg, to introduce the chairpersons for the day.
So, good morning, everybody. So it's my pleasant duty to introduce the chairpersons for this very prestigious e-masterclass in pediatric rheumatology. As we started this program 2 weeks back, today is the third session, and the response has been excellent. IAP Delhi has been it has been an academic forefront as far as a lot of activities are concerned, both on physical and Zoom platform. Last 2 years with the help of Dr. Ajay Gupta, our scientific coordinator for the day. So today that discussion is going to be on spondyloarthritis. Many times we feel that this spondyloarthritis, or what normally used to be called ankylosing spondyloarthritis, is a disease of adults and children don't get it much. So Dr. Narendra Bagri will be doing that. But before that, it's my pleasant duty to introduce the chairpersons. We have two chairpersons today, and we have Dr. Manish Mehta. Dr. Ajay, can you see the slide? Dr. Manish Mehta is our CIP EB member from Gujarat, and he's a very senior pediatrician, and we are very happy to welcome you, Dr. Manish, on our platform. Welcome you, sir. Dr. Manish Mehta, yeah. So he's EBCIP 2025, and he was past secretary of AOP Gujarat, past president of AOP Ahmedabad. He's trainer in ALS, BLS, Advanced NRP, TRIP, United Airways, and a lot of programs. He has his affiliation with Synergy Neonatal and Pediatric Center, Ahmedabad, Cyril Neonatal and Pediatric Hospital, Ahmedabad. So we welcome you, Dr. Manish Mehta, on this platform.
Thank you.
Welcome. Yeah, thank you so much, sir, for gracing the occasion and for sparing time for IAP Delhi on this platform. The other chairperson is EB from Kerala, is Dr. Bennett. So he's consultant HOD Pediatrics, WNC Hospital, TBM. He's state academic coordinator of BNRP Kerala, chairperson of NISS Trivandrum, state adoption committee member, state ethics committee member, and he is affiliated with Kerala Government Health Services. And he has many major achievements and awards, publications to his credit. So thank you so much, Dr. Bennett, for making it to come to IAP Delhi platform on early Sunday morning. Thank you both the chairpersons, and I hand over to Dr. Ajay Gupta for the proceedings. Dr. Ajay.
Thank you, Pankaj. I request Dr. Manish Mehta, sir, to please say a few words.
Yeah, good morning. First of all, I thank Dr. Ajay Gupta and the team IIP Delhi, Dr. Pankaj Garg sir and Dr. Meena for inviting me as to chair this prestigious session. As I went through, you have kept a great series of rheumatological disorders, because this is something which is very much under discussed, and what we say is our eyes can't see what our brain doesn't know. So if we don't listen to all these things, we are not going to suspect all these things. And probably after COVID, what you have seen is a rising in the inflammatory disorders compared to the infective conditions. And because of lots of preventive work done by this government, we are going to see more of these inflammatory disorders in future. Particularly, your health, your lifestyle changes are also affecting all these things a lot. As we discuss ankylosing spondylitis and spondyloarthritis, so these are all disorders of more of juvenile and adolescent. So sometimes, as sir said, we think more of an adult thing, but it's actually more of a juvenile and adolescent children also get affected. And if we don't know about it, we are never going to suspect about it, how to diagnose them. It's more of a clinical diagnosis, less of an investigation, and early suspicion can have prevent lots of morbidity in future. So it's going to be a great discussion today, I'm sure. So thank you once again for inviting me to chair this session. Thank you.
Thank you, Dr. Manish. Now I request Dr. Bennett sir to please say a few words and introduce the speaker for the day.
Okay, sir. Thank you very much for inviting me for such a wonderful day. That is on Sunday morning itself. It's a good time to learn the most important topic in our day-to-day life, especially ankylosing spondylitis, because it's usually we don't see or we don't detect these cases of arthritis in our general practice, especially being a community practitioner. We never used to come across all these cases. But I think most of the time we are not coming across because we don't know what is this type of arthritis are going to see. And by learning about all these things, then only we will come to know that. See, what the mind knows that only the eye can see. That is the thing with the arthritis, I feel. Because most of so many children will come and say that I got this pain, I got that pain. We are common tendency is to neglect the thing. Anyway, this is a major and wonderful occasion to learn for everything. I got surprised to see after seeing these programs conducted by Dr. Ajay Gupta. Thank you, sir. Thank you very much for inviting me for chairing this session. And it will be a great honor for me also. And it will be a learning for me also. Thank you very much. And wishing all the best for this program. Thank you.
Thank you. So please introduce Dr. Bagri. I have displayed this.
Yeah, Dr. Narendra Bagri is from All India Institute of Medical Science. It's close to my heart because I studied in Delhi Army Hospital R&R, and he's an additional professor. He's a division pediatric rheumatology and clinical immunology department of pediatrics AIMS, and his fellow he got a fellowship in pediatric rheumatology. It is a rare degree for so many pediatricians because so many pediatricians are there, but pediatrician with rheumatology degree is very less. Anyway, his main interest is autoimmune inflammatory syndromes and inflammatory arthritis and inflammatory myositis. Thank you very much for presenting this program and welcoming you for this wonderful morning.
Thank you, sir. I request Dr. Bagri sir to please start sharing his presentation. Dr. Anu, would you like to say something? Yes, sir. Screen is visible, sir.
Yeah, it's visible.
Just give me a second. Is it visible?
Yes, sir.
And am I also visible? I just want to put my video on so that I stay connected. I think
yes, sir. Now visible.
Perfect.
Right. Everything is fine. Yeah.
Okay. So good morning, one and all. And thank you, everyone, for giving me this opportunity at this platform. And as rightly mentioned by my colleagues, that these disorders are often not coming to the knowledge. And I have tried to cover the things in a way that it becomes more like a myth buster rather than too much of scientific stuff. I mean, there is a scientific stuff, but the key is to decipher the myths surrounding ankylosing spondylitis that Dr. Pankaj Garg initially mentioned that this is a disease of adulthood. So by the end of this talk, I think I would be able to convince the audience with the fact that this do very well affect kids, number one, and these are treatable disorders. And number two point that I want to highlight is what Dr. Bennett was telling, probably these disorders are not coming to pediatrician, and that there is a specific reason for that. And in a while, I will tell you, we need to streamline the referral patterns, which will probably make the things easier. Okay. So to begin with, so during next 45 minutes or so, we will go through what exactly is the disease, what are the diagnostics, I mean, how to diagnose this disease, the broad principles of management, complications, and the way forward. So let's begin with this, and I would appeal all the attendees to be interactive and just keep on posting your questions or comments on the chat box. So, Dr. Anu, may I request you to please keep a check on the chat box and feel free to interrupt me. So this is a 12-year-old boy who was presented with fever, morning stiffness, low backache, left knee arthritis for quite some time. He visited us in the August of last year, but he was symptomatic for last 3 years, 3 months or so. And the MON2 was positive. So thoughts, any differentials? And don't get skewed. I always keep on saying that since it's a rheumatology talk, please be open. Think what could be the broad possibilities as a physician, and then probably we'll make it more interactive. Any thoughts? I would appreciate any comments in the chat box. If there are any. Tuberculosis, perfect. What else? Okay, so that exactly was the thought. Thank you for putting this. And this was exactly what happened. So there was
Someone has mentioned sickle cell disease also.
sorry, which disease?
Sickle cell.
Okay, sickle cell, fine. Okay, anything else? Okay, so tuberculosis and sickle cell are the things which have been put forward. Okay, so apart from this low back pain, left knee arthritis, subsequently the child also had developed right knee arthritis, bilateral ankle arthritis, and heel pain. So pay due attention to the heel pain, low back ache, and I will try to convince you. So as rightly mentioned by one of the colleague that is possibly tuberculosis, and hence the child was starting on ATT, but without any further advantage. And during the while the child was getting ATT, he developed other manifestations, including the arthritis of the knee and ankle joint and the heel pain. So actually, and this is again one thing what is happening, and this is probably one of the reason why these patients are not seen by the pediatricians. Dr. Bennett, I need your attention here. So you can see there are a lot of alternative medications. I don't know what treatment this patient is receiving, but this is the actual picture of the patient. He underwent this therapy. I would be happy to know from the audience if anybody is aware about this particular therapy, but this is a very painful state of affairs that what is happening around with these patients. So that's one. Number two, can you see on this image? Then they visited someone. So who might have put this plaster cast? Any? I mean, my question is, to which group of physicians the patient has landed to?
Orthopedician maybe.
Perfect. So with all due respect and regard, that is why these patients are not coming to pediatricians, and there is a huge gap in knowledge of the laity and the physicians, because of which there is apparent gap in the referral pattern. And the orthopedicians I hope that there is no orthopedician around in the group, but even if it is so, with all due respect and regard, they won't hesitate to do some procedures and casting the patient in a plaster without any further advantage. And when the patient reached us on top of tuberculosis and these plaster cast and these some alternative therapy, which I don't know what exactly the patient was going on, and he actually reached us in a logwood kind of position where fixed deformities of the knee and totally fixed spine. So this coming to the whole list of arthritis, we have lots of causes of arthritis. But for today's talk, we are focusing on juvenile idiopathic arthritis. I won't dwell deep into this. My colleague, Dr. Anu, might have discussed this in the previous talk. So for coming to the index case, that patient, just believe me for a while, that patient was not tuberculosis. The tuberculosis was erroneously diagnosed and was unnecessarily subjected to anti-tubercle therapy for some time. That patient was actually one form of arthritis, that is juvenile idiopathic arthritis. And in that particular group, was suffering from what is known as enthesitis or spondylitis or ankylosing spondylitis or juvenile ankylosing spondylitis for that matter, which is the topic for today's discussion. So what exactly is ankylosing spondylitis? It's a Greek word which means there is ankylosis, which means bent or flexion of the vertebrae, as seen in this child who has developed a flexion or deformity, a completely bent, there is a flexion deformity of the entire spine with limited mobility. So this is ankylosing spondylitis. Okay. So apart from the axial joint involvement, there could be other manifestations of this disease as well, which I won't dwell too much into depth, but you should know that the anterior uveitis is one of the complications for this disorder, psoriasis and inflammatory bowel disease. So let's come to what exactly the ankylosing spondylitis is as far as adults are concerned. So Dr. Pankaj was mentioning that this disease is predominantly found or mentioned in adult, and they define the ankylosing spondylitis as someone who is having chronic back pain for more than 3 months, along with the radiological feature of sacroiliitis or the other features of spondyloarthritis, which include low back inflammatory pain. By that, low back inflammatory pain with morning stiffness more than 30 minutes is considered as inflammatory back pain, or arthritis, uveitis, psoriatic form skin lesions, dactylitis, or other features like Crohn's or colitis. Along with the family history of spondyloarthritis or HLA-B27 positivity, on top of elevated inflammatory markers, would qualify someone to have ankylosing spondylitis in adults. Okay, so this is the story about adults. But then, do this disease affect children? So the answer is yes. And what do we call this disease in pediatric population? So in pediatrics, we call the adult equivalent of spondyloarthropathy in pediatrics is enthesitis-related arthritis or spondylitis related to JIA. And it is characterized by peripheral arthritis and enthesitis. I will shortly tell you what exactly is enthesitis or arthritis or enthesitis plus two of the following, which includes sacroiliac joint tenderness, and it will manifest as inflammatory back pain, presence of HLA-B27 positivity, acute symptomatic anterior uveitis, and a history of spondyloarthropathy in first degree relative. So this will classify for enthesitis-related arthritis or this. I would appreciate the response from the audience. What exactly is shown in this image on the left-hand side? What do I want to show?
Swelling of the Achilles tendon.
Perfect. So what is this known as?
Achilles tendon, someone, doctor.
There is some keratinization also, no?
Sorry?
Keratinization also.
Skin
Yeah,
also.
so typically what I would...
hyperpigmentation is there.
Yeah, that's the hyperpigmentation, but more important thing that I want to show, if you compare both the ankles from the behind, you can see this tendon is moving smoothly, getting attached, but here there is a swelling, and this is big, and this patient was complaining of heel pain. If you could recollect, the first patient I discussed was also complaining of heel pain. So this is what is characteristically known as enthesitis related arthritis, and the enthesis is nothing but these dots. These dots are the sites where our tendons and ligaments attaches. Can everybody appreciate this? And the most common site of enthesitis that we see in pediatric population with this group is this particular, that is heel pain, where the tendoachilles attaches, and the patellar insertion of the quadriceps femoris. This again is a site for enthesitis. So apart from frank arthritis, these patients will complain of pain at these sites. So we should know that these are the points. These are the vast number of points, but simply speaking, you must ask a history of heel pain and a tenderness around the knee joint, which is classically at 2, 10, and 6 o'clock position at the knee joint. So this is the site of enthesitis, and this is one of the important hallmark clinical manifestation of the disease which we are discussing today. Okay. So now coming to, do we get this in pediatric population? So answer is yes. And how common is this? So this probably would be important for everybody. I want everybody's attention here that if you go back and see the classic textbook of pediatrics, they will say that the most common subtype of GIE, and I think Dr. Anu might have covered this in the previous talk, is oligoarticular GIE in the Western world. But in our world, I mean in Southeast Asia, and this is data from our center, where around 40% of the patients with, this is the data of around 1,000 patients, where 40%, which means around 400 to 500 patients over a period of like 9 years, are having enthesitis-related arthritis or ankylosing spondylitis in pediatric subgroup. So the key message is this is the most common subtype of GIA in our country. And therefore, the disease is not restricted to adults only. It has a very well, and rather the most common subtype of juvenile idiopathic arthritis in our country is enthesitis-related arthritis, characterized by the clinical features which I mentioned a while ago. Okay, so this, everybody is comfortable that this is the enthesitis. Can anybody point out what I want to show in this particular image?
Swelling at the...
Yeah, swelling is there.
Yes.
Right.
Where is the swelling?
Ankle.
Ankle.
Okay, actually, this is bit beyond ankle. And if you see, this is midfoot arthritis. This is, so if you compare this versus this, of course, this is the midfoot area is more swollen. So this is known as tarsitis, and this tarsitis or midfoot arthritis is again very characteristic feature of the entity that we are discussing today. So if you, at times, some patients may complain of midfoot arthritis, not the ankle arthritis. So this midfoot arthritis, heel pain are characteristic feature of the disease that we are discussing. Okay, so how does this disease differ from the other subtypes of GIA? I won't touch upon the other subtypes, but what you should remember is typically this is a disease of adolescents. These patients will usually come around 7 years, 10 years age, and then more common in males, predominantly lower limb involvement. And this is again important. I mean, whenever a young boy comes to you with asymmetrical joint involvement, mind by every word, asymmetrical, meaning thereby, if you can recollect the first case that I showed, that patient had low back pain and then he developed the left knee joint, and then subsequently he developed the right knee joint involvement. So there is not symmetrical involvement, it developed asymmetrical joint involvement along with axial skeletal involvement and associated enthesitis and tarsitis, which I have shown you in the previous image, are characteristic clinical features of what is known as enthesitis-related arthritis in children. They usually don't have hepatosplenomegaly lymphadenopathy as opposed to the systemic onset GIA. Another important complication of this particular entity is acute symptomatic uveitis, and by that I mean they would often present with acute red flary eye. In contrast to the uveitis, can anybody tell me what is the type of uveitis in other forms of GIA? Happy to have comments.
Chronic versus acute, right?
Yeah, so that's more important. And by chronicity, I mean they usually would be symptomatic, but here usually it will be more symptomatic. By that will be red flary eye. But having said that, it is acute and symptomatic. At the same time, this can again be disabling in terms of the visual outcome. And usually 80 to 90% of these patients will be HLA-B27 positive. This again is an important point. But at the same time, HLA-B27, mere presence of HLA-B27 is not equivalent to ankylosing spondylitis. Many a times the patient will come that my HLA-B27 positive, am I having this disease? So can I have a quick comment from anybody that what is the usual percentage of HLA-B27 positivity in normal population?
15-20%.
20%.
Yeah, a bit high. In our population, it is around 6 to 8% in our population. And what I mean to emphasize by this fact is that just mere presence of HLA-B27 positivity is not equivalent to ankylosing spondylitis. HLA-B27 positivity along with these features would of course qualify for HLA-B27 associated arthritis or ankylosing spondylitis or ERA. These are all more or less synonyms. Okay, so far so good. Let's move on to this case. Low back pain, mild fever, weight loss. The CRP is raised, MON2 negative. X-ray shows unilateral sacroiliitis. Thoughts?
For us, sacroiliitis means ERA only. We don't. I think there's any other differential. I don't know.
Okay. Any other thought? So there is obviously a sacroiliitis. Here, you can see the erosions and this aligned sacroiliac joint. So unilateral sacroiliitis, fever, weight loss. Perfect. So actually, I'm going to, so possibly we have this dilemma. Infectious, inflammatory. I don't know, can we have a quick chat in the chat box in favor of TB versus inflammatory so that I can dwell more.
The answer box is working, so please ask them to comments in the question answer box.
Yeah. So it's important. It's really important because this is what I want to, the purpose of, so that Dr. Ajay's vision is taken to the extremes and every spread well. This is important. And these cases are real cases. And I will tell you why it is important. Quick comments in the, so this is a unilateral sacroiliitis with a bit of fever and weight loss going on for some time with raised inflammatory markers. Any comments in the chat box? I am not able to see.
The question and answer box, there's a single joint arthritis TB.
Okay.
You have to see for collaborative evidence of TB.
Okay. Okay. So
And
actually, yeah.
inflammatory joint have gelling in the morning.
Okay, fine.
Yeah.
Perfect.
We have to think of reactive arthritis also.
Perfect. Perfect. Okay. Okay. So let's move ahead. So what exactly was done in this patient was before he came to us was again, because of the history of weight loss, unilateral sacroiliitis, someone started anti-tubercle therapy. That's so far so fine. So what happened down the line is he started having pain in ankle joint, foot, while he was on ETT, neck pain and restriction of movements, difficulty in opening mouth. And you can see that what has happened here is he has developed the cervical spine involvement as well. And the inflammatory markers were high. And there was sacroiliitis on MRI as well. There was involvement of the hip joint, synovial effusion, and the sacroiliitis. And this is has led what has happened during the course of time. Can anybody comment? So the child
Joint destruction.
yes, so there was a joint destruction because of the probably a false assumption that we were dealing with tuberculosis. And actually, this case was, if you look back, this patient was having inflammatory back pain. As someone rightly pointed out, there was a significant history of morning stiffness. And on top of that, subsequently, he developed other joint involvement. And because he was not getting the definitive treatment for the inflammatory arthritis, rather, he was just getting ATT, this gave enough time for this child to develop the atlantoaxial dislocation. And this, though rare, can be life-threatening complication of juvenile idiopathic arthritis. So what have we? So again, this is HLA-B27 was positive. And so I just want an opinion from the house that are you convinced with the fact that this child was not tuberculosis? I will tell you in a while why it was not tuberculosis. But are you convinced with the fact that this child was actually spondylitis related GIA or enthesitis related arthritis? Are you convinced?
Yeah. Now we are convinced
Yes.
because the later on history tells everything.
Perfect. So now I will tell you why you should get convinced at the first instance as well. So there is again a misnomer that misunderstand. And so then this is a brief course of the child that he did well after starting an sulfasalazine and adalimumab. I will come to this later. But yes, to begin with, I mean, let's come to, there is probably a misunderstanding that unilateral sacroiliitis is tuberculosis, but this is not the fact. So from this case, if you take the key message is that unilateral sacroiliitis is not tuberculosis, not always tuberculosis. In fact, honestly speaking, I haven't seen a unilateral sacroiliitis presenting with tuberculosis as of now. And probably those who are dealing with joint pain and arthritis would agree with me. So, but whenever you have there is some sort of this teaching that unilateral sacroiliitis, one must think of tuberculosis, but the answer is simple. You need to knock down the door of your radiologist and find these possible differences. The sacroiliitis that we have seen in this particular child was usually iliac dominant marrow edema was there. There was joint enhancement, and apart from there was also features consistent with enthesitis. So in contrast to that, tubercular sacroiliitis would have large erosions, osteomyelitis, pestrum, and sort of other things. It's not simple. So it is, there is some, yeah, yeah. So basically, so the lesson from this particular case is unilateral sacroiliitis is not tuberculosis, and there are significant differences between infection
slow.
sacroiliitis and inflammatory sacroiliitis. So coming to the diagnostics, so we have learned that by now the inflammatory arthritis or ERA or spondyloarthropathy arthritis is the most common subtype of GIA, number one. Number two, the characteristic clinical features are enthesitis, number one. Number two, low back pain. Number three, tarsitis. And sacroiliitis, even unilateral to begin with, could be an inaugural presentation of this, and we should not label every case as tuberculosis as has happened in both of these cases. How do we diagnose this? So the diagnosis of these cases is chiefly clinical. And if you recollect from the first talk from Dr. Sujata, that she characteristically mentioned that most of the diagnosis in rheumatology is from clinical history taking examination. And this holds true for, I think, every specialty. There is no substitute to clinical history taking examination. What amount of artificial intelligence or error can come? But there is no substitute. This is for the youngsters. and the postgraduates if they are around. So, but yes, the other imaging, the diagnostics which can help us is for two reasons. One, we need to do a hemogram for the baseline ruling out sinister causes, inflammatory markers just to support that there is ongoing inflammation. And then, of course, if we start the treatment or the immunomodulation, we need to monitor the side effect of these drugs. And that is why we need to do routine hemogram and the LFTs and KFTs. And then imaging is an important aspect for making the diagnosis of uh, spondyloarthritis. So this is the radiographic definition of sacroiliitis, which is characterized by the presence of erosion, sclerosis as seen here, or overt ankylosis. So sacroiliitis may be present in around 40% of the children with the ERA, although it could be clinically silent in around a fourth of the patients. So this is the radiographic definition of sacroiliitis. But at the same time, by the time the time taken to reach to these overt radiological findings, there is often a time lag from the onset of symptoms to these radiographic changes. By that I mean, typically you will get the MRI findings first compared to the radiographic findings. So in clinic, how do you exactly see that some patient is having a particular restriction of the lumbosacral spine, and this is what is known as Schober's test. I think everybody is aware about this, but for just recapping for the postgraduates, you just take the dimple of venous straight line here, you take a 5 centimeter mark above this, and then you take a 10 centimeter mark about this, uh, and then from the you ask the patient to flex, and if the increase in the distance is less than 5 centimeter, it is considered as restricted joint mobility. Okay. As I told you that MRI would pick up the sacroiliitis or the inflammatory changes earlier than the X-rays. What MRI should you request? So ideally speaking, you should get contrast, which is ideal for assessing the activity of the disease, and you should advise a contrast MRI for sacroiliitis. And this is the classic finding that you will get the marrow edema, abnormal enhancement of the sacroiliac joint, and along with that, hip joint involvement. So apart from the sacroiliitis, hip joint involvement or hip pain is again an important manifestation of ankylosing spondylitis or the children with ERA. Okay. Another thing that I was talking about was HLA-B27. So HLA-B27 should ideally be tested using PCR technology, and this is present in around 80 to 90% of patients with ERA, and the presence of this along with low back pain and other features are in keeping with the diagnosis of ERA. Okay, let's move on to this case. Left knee arthritis for 1.5 years. And again, this is one of the reasons, Dr. Bennett, you can see that why this patient was not with you.
Yeah.
Can you see? He went somewhere else.
No, I am here.
No, you are here, but I'm
Yeah.
talking about
The patient went somewhere else.
Yeah.
rather than pediatricians, he went somewhere else, and as a surgeon, they were tempted to do some
Surgical procedure. Yeah.
surgical procedure. So lots of
How to do this ultrasound, no?
Okay, so thoughts. Monoarticular arthritis is a huge problem. Whenever a child with monoarticular arthritis, you will keep on thinking. So, are you happy with the approach and treatment which this child has received? Anti-tubercular therapy, monoarticular arthritis. Let me hear. Boy.
Yeah, they have done what the surgeon have done. They have aspirated the joint or they have incised the.
They have not aspirated. It is much more than aspiration.
They have incised it.
They opened the joint. They
Opened the
opened the joint.
They have opened the joint. Fine.
Yeah.
So here, actually what has happened is, again, a possibility of tuberculosis was kept, and this was smooth synovial proliferation. The bones are intact. So here again, down the line, what happened? Can someone pick out? What is happening to this child here?
Uveitis has happened.
Uveitis, left,
Yes.
right.
While this child was probably mislabeled as tubercular arthritis, has undergone procedures which was not actually warranted, and down the line, he was getting ATT, on top of which he get acute red flary eye. Now, can you club together everything?
Yeah, it's now ERA.
Fine. So this is enthesitis-related arthritis. So again, this is the lesson from this case is even the ERA, monoarticular arthritis, could be an inaugural presentation. And you see that in most of these patients, this is series from us, which is not yet published, but 54%, more than half, are unnecessarily exposed to tuberculosis and the orthopedic interventions. And this is probably because of the aberrant referral patterns and the poor understanding of the laity that whenever you have joint inflammation, you have to reach to orthopedicians. We need orthopedicians, but for some reasons, I will tell you when do we need them, but not for treating the inflammatory arthritis for sure. Okay, so the lesson from this case is monoarticular arthritis, particularly the hip joint and knee joint, infradiaphragmatic joint involvement at beginning can also be inaugural presentation for ERA. And then again, rightly, how do we differentiate between tuberculosis and the inflammatory arthritis like ERA or spondyloarthritis? So the synovial thickness, as we have seen in the previous case, was less, was smooth, and there was no significant non-necrotic node, and there was no intraosseous abscess. So you need to ask these particular questions to the radiologist that what are we dealing with? So tubercular arthritis vis-a-vis the arthritis in inflammatory arthritis is usually we see a smooth synovial proliferation in contrast to dirty synovial proliferation and bony erosions in tuberculosis, which is in contrast to the monoarticular inflammatory arthritis. Okay, so having learned the overall clinical spectrum of these disorders, they can present with monoarticular arthritis, they can present with low back pain, they can present with enthesitis, they can present with uveitis. So this is the broad spectrum of presentation of these patients. Once diagnosed, how do we manage? So as these patients have multi-system involvement, we need a team, and the team include the physician, the ophthalmologist, the physiotherapist, the physiatrist, and at times, if the disease is too advanced, at that point in time, we need orthopedician, but not at the beginning. I will show you when we actually need them. And I won't dwell deep into as I was discussing with Dr. Ajay, I'm not dealing deeply into the management principles. Broadly, this is what we follow. Typically, these patients will respond well to naproxen, which is given, and then we start with methotrexate or sulfasalazine. Sulfasalazine has got a better edge in terms of efficacy compared to methotrexate in ERA. And then if the child typically don't respond within 3 months or so, we will start biological agents. And the biological agents here are anti-TNF agents, whether etanercept or adalimumab. If there is associated uveitis, preferably adalimumab is the drug. Apart from that, if there are 1 or 2 joints involved, you will consider giving intra-articular corticosteroids as well. Okay, so in addition to the biologicals, there is also these days the drugs coming are JAK inhibitors, and yes, they also have an efficacy in the sacroiliitis. Secukinumab again has an efficacy in the sacroiliitis group. Okay, so a brief video, but before video, I just want to have quick comments from the audience that how many of you have actually performed an arthrocentesis?
I have never done it.
Perfect. Anybody?
Never, sir.
So, okay. So let me, by the time you see this, let me ask the question other way around. How many of you have performed a lumbar puncture? Or for that matter, how many of you have put a central line?
All of us.
All of
All
us.
of us.
So
Yeah.
this is
During
this-
PG days.
perfect. So this is a lacunae in the teaching and training, and I'm thankful to Dr. Pankaj, Dr. Ajay, and Dr. Anu and team that they chose this platform to decipher this message that this is much simpler procedure than the central line, then the bone marrow, and then many procedures that pediatricians are comfortable with. In fact, I can say that at times I remember during PG days, there have been instances where anesthetists used to call pediatricians for intubation when they were struggling with a small kid. Do you agree, Dr. Pankaj and others?
Yes, that happens.
Yes. So, yeah. So, but what I mean to say is that this is a very small and simple procedure, and you can see that this is important. This is just nothing but probably a mental barrier that we can't do it. So, I would request a simple procedure. This is online video available on the site of Indian Pediatrics. You can look into this. So, the important thing is that Yes, we can aspirate the joint and we can also inject. It's a very simple procedure, and this is important at times for diagnosis and for therapeutic advantage as well. Okay, so let's move further. So once we have diagnosed, and these intra-articular corticosteroids are given when the number of joint involved are less than 4 or so. So apart from the drug management, this again is equally important. Often we ignore this part, and this includes physiotherapy, and you should have a team of physiotherapists well in place to help us. And then at times, this is where actually the orthopedicians, honestly speaking, we should avoid making them busy or taking their opinion because of the fact that we actually don't want these surgeries to be performed in these patients. So here is a child who has been neglected as a case of tuberculosis and all sort of things before he developed this ankylosis of the hip joint, fixed deformity, for which he has to undergo this hip replacement. So hip replacement is an option, but actually speaking in ideal word, this probably is a reflection of failure of the entire treatment and the journey of the child. This has happened. The child has reached this stage because probably somewhere the diagnosis was delayed, somewhere the treatment was delayed, somewhere he was not in poor follow-up, he was in poor follow-up, and then eventually has to reach this stage. So ideally, we should not reach it, but yes, if needed, we may have to consider hip replacement for improving the overall quality of life of the children. So there are challenges for hip replacement in pediatric population, and particularly because the lifespan of the graft is of the replacement replaced hip is limited. So we have ideally most of the orthopedicians will consider replacing it when the skeletal maturity has achieved. Okay, so what happened to these children over the time? So over the time, you see that the most common subtype of GI in our setting is ERA, and this is data from our center, and more than 50% will have some form of articular damage. And by damage, I mean they would have some fixed deformities in any of the joint. And extra-articular damage, and as told, that uveitis is the most common, affecting around 1/4 of the children with ERA. Our performance is a bit poor than the more developed nation, probably because we are running short of, or because of the poor access to more effective drugs which are available these days, that biological agents. And you can see that they're in these cohorts from Greek and Singapore, the damage is 6% only, contrast to almost 50% in our settings. So we need to work on this. And these are the factors associated with, you can see that the prolonged disease duration is an important marker, is an important predictor for the overall disease damage. Okay, so this is about JIA uveitis. So this picture, can anybody suggest what I mean to reflect here?
So how child is going to see with uveitis? Like how
Perfect.
his vision is
Yes,
going to
so
be.
this is exactly the visual blurring that the child will experience with uveitis. And around 20-25% children with the ERA can have uveitis, usually acute, but at times chronic. And you can see that the complications can also happen with this. So therefore, there is a need of regular screening of the children for uveitis as well. So by that, I mean you have to collaborate with your ophthalmology colleague and preferably sit together to screen these and treat the uveitis together, because in uveitis, the ophthalmology, the treatment of uveitis also will include the immunomodulation drugs after the topical drops have failed. And in summary, if the need for the topical eye drop, the topical steroids is more than 2 drops per day, we will consider using the immunomodulators. So as I was telling that this could have a blinding complication. You can see that in our cohort, a couple of patients also had blindness despite available therapy. And this was probably because of the neglected uveitis at the first onset. Apart from uveitis, they can also have poor bone health, which is characterized by low bone mineral density in around 50% of the patients. Okay, so this is one of the complications which I have shown you in the child which had atlantoaxial dislocation. So we have learned that there is a damage to joint, there is a damage to eyes in ERA. Can it affect something beyond joints? What is this? Any thoughts?
Regurgitation.
Sorry?
Aortic regurgitation.
Yeah,
There's
actually, this child had again erroneously labeled as rheumatic heart disease and had underwent a mitral and aortic valve replacement, which was actually secondary to ERA or spondyloarthritis. This child was having polyarthritis, low back pain, and he was just getting penicillin rather than getting the immunomodulation, and the ongoing inflammation in ERA or spondyloarthropathy can also lead to cardiac involvement, including MR and AR, which is an important complication of this disorder. So this case is just to illustrate the need of timely initiation of immunomodulation so that the damage can be curtailed. Apart from this, if uncontrolled, they can also have disorders like amyloidosis. So once we have learned about, probably this is my last or so slide, that if we have the children with ERA or spondyloarthritis, usually we will start with the immunomodulation. A multimodality team approach is needed, but 1/3 to 1/4 of these children will often have relapses during adulthood. Therefore, it is important to ensure that the transition of care has to be ensured while they turn adult and has to be transferred to adult rheumatologists. So I think the key discussion points and lessons that we learned from this presentation is, first thing is preventable cause of disability. As you have seen that many of these kids have undergone disability, including the hip replacement, one has got wall replacement, someone has gone blinding. This probably all of these are preventable causes of disability. That's the key. And as a President IIP or Pankaj, I'm probably requesting you to spread this message as wide as possible, because I'm getting a bit sentimental because of the fact that this is preventable cause of disability, and if we can prevent this, we're ensuring an intact survival to the child and to the society. So that's the key. Number two, misdiagnosis. I have shown a couple of cases where all of them has been mislabeled as tuberculosis. So unilateral sacroiliitis is not equivalent to tuberculosis. Monoarticular arthritis is not equivalent to tuberculosis. Even for that matter, arthritis is not equivalent to tuberculosis. And this is happening because probably lack of awareness among the physicians and among the laity, that the referral patterns that we have seen, that often these patients are landing up to the referral pattern not streamlined. In my opinion, they should first visit the pediatricians. Bone pain, arthritis, arthralgia, it is in the prerogative of the pediatrician to look whether it is inflammatory arthritis or it is something traumatic arthritis which would need orthopedic intervention or something like that. But primarily they should reach to a pediatrician. And the early identification is the key to prevent the disabilities. And of course, one of the important things is streamlining the referral pattern. Thank you so very much, and I will acknowledge everybody who has helped me in this presentation, and patients and families. Happy to take any questions or comments.
Thank you, Dr. Narendra Bagri. It's an excellent talk and nothing more to say. But I got some small doubts regarding the...
So please stop sharing the screen.
Yeah, sure.
Shall I ask?
Yeah, please go ahead.
Please go ahead.
Please, some doubts. See, it is for enthesitis arthritis, you said that it is always asymmetrical. No, always, asymmetrical. But what I read, whether I am correct or not, I am not very sure. Initially, it will be asymmetrical after some time, like say after 6 months or so. It becomes symmetrical to say that it is enthesitis arthritis. Is it correct or any?
Yeah. What I mean to say is that to begin with, these patients can have asymmetrical arthritis. Like the cases I shown, usually they can have hip joint involvement or the knee joint involvement. Down the line, they can have polyarthritis. I mean, the other joints can be involved, but typically the lower limb joints are involved.
Later, it can become a symmetrical arthritis. Initially, asymmetrical. Then,
no, it's not the rule.
It's not necessary that everyone has to go as symmetrical. Am I right?
Yeah, it's not the rule. It's not.
Okay. Second thing is, so how early you can start the treatment? Like you start with naproxen. When you will decide that immunomodulation to be done?
Okay, I think whenever you have a diagnosis of ERA, you have to start the immunomodulation. But because usually most of the time these patients will often come late to you. So by that time, I mean, if there is overt sacroiliitis on MRI, you have to start, or for that matter, an overt arthritis. If there is monoarticular arthritis, for instance, there is no sacroiliitis. In that case, you may start naproxen and give intraarticular steroids. Okay. If there is critical joint involvement, by that I mean if there is hip joint involvement, there is sacroiliitis, there is cervical spine involvement, you have to start the immunomodulation upfront. By that I mean you have to start sulfasalazine in this group of patients. Ideally speaking, you should start even biologics upfront if there is sacroiliitis.
Like etanercept or something.
Yes, adalimumab is preferred because it also works well on uveitis in contrast to etanercept.
Okay,
But
thank you.
while using biologics, it's again important. They are quite effective, but at the same time, it comes with some cost. And the cost here is reactivation of tuberculosis. There is around 3 to 4-fold increased risk of tuberculosis reactivation when these patients are subjected to anti-TNF agents. So meticulous screening prior to starting biologics and during the course of biologics is needed.
See, before starting naproxen, is there a role for paracetamol and brufen, which is a normal basic drugs in our practice?
No, I think this is inflammatory origin of arthritis, and we have to use a potent anti-inflammatory agent, and that would be something potential COX-2 inhibitor like naproxen.
Thank you very much. Thank you very much. Okay.
Sir, most of the smaller cities and smaller places don't have rheumatologist access. Like in Gujarat, if we say maybe Ahmedabad and Surat, these two places may have rheumatologists. So a small city pediatrician who is suspecting this type of disorder, like is there up to any extent he can treat this condition? He has to straight away refer to rheumatologist whenever he suspects it.
I mean, it's a bit of tricky question, but I would simply say what is the if someone is comfortable in treating, I'm not big fan of, because there are logistic reasons. At times the patient may not reach the place, and in that period in time there is no right answer here. But yes, one should know how to treat, then it can be treated anywhere, and that treatment is the guidelines that I told you, that that you have to start with naproxen, intra-articular corticosteroids. One more thing that probably I didn't mention in the lecture is that often people give long-term systemic corticosteroids. So long-term systemic corticosteroids, by that a systemic steroids of more than 3 months is not advocated in non-systemic GIA, including ER and spondyloarthropathy. So yes, so and at times good teamwork would suffice the management.
Yeah, because most of the time what happens that people refer to orthopedician early and they start naproxen in whatever inflammatory
So
joint
at
condition.
least
Yeah.
the key request is don't refer to orthopedician.
Yeah.
I mean, with all due respect and regards, but you can understand why I'm saying so.
One more thing with the orthopedicians, they always put on splint for
Yeah,
any joints only. That also is
yeah,
not
exactly. It's splint, and it's natural because
it's a good information for me. Actually, I thought that you have to put it in splint at least in the initial stages.
no hard evidence for that. No.
It may be due to financial reasons also. They have to do something.
Yeah, I don't want to bring that into that platform.
Sir, we have a question by Dr. Vidya. We have a patient of sickle cell trait with JIA, 4 large joints involved. Do we need to add hydroxyurea with the JIA management?
So what I can infer is Vidya is telling that there is a patient with JIA and sickle cell both.
Mm-hmm.
Yeah.
Sickle cell trait.
Probably it's the coexisting sickle cell disease.
Yeah, usually because sickle cell arthritis is acute arthritis. That's very painful arthritis. That's different from the inflammatory arthritis that we are discussing. And if by chance, if there is coexistence, then we have to treat GIA like the way we are treating here.
Because sickle cell disease is quite common in some parts of Maharashtra, and they may be coexist.
Yeah. So in that case, we have to treat the inflammatory arthritis as well.
Dr. Amit Sohal has asked, inflammatory arthropathies in children, sudden increase in their incidence, is it due to gene involvement or interaction with rapidly changing environmental conditions, or is the COVID infection to be blamed for these conditions?
I think nothing has to be blamed for. The real answer is probably one is increase in awareness. And I don't there is an evidence that, of course, these inflammatory disorders, overall inflammatory disorders, are on rising trend, but there are a host of reasons for this. But more important is probably the increase in awareness that these disorders, inflammatory arthritis, are one of the myths that was probably we should burst out from this session, is that inflammatory arthritis do affect, including ankylosing spondylitis, do affect pediatric population.
There's one more question. Could IGRA be used to confidently rule out tuberculosis?
IGRA is rule. Okay, this is a good question. In fact, a great question, but no right answer. But I mean, right answer in terms of screening. But it is important to screen all kids, particularly in whom you are going to start biological agents. And what we follow is, because IGRA is costly, what we'll do is we'll do a MON2, a chest X-ray. If both are negative, in that case, probably just to be doubly sure, we go ahead with IGRA. But if MON2 is positive, in that case, we don't go ahead with IGRA, because just it's a mechanism, cost curtailing mechanism. But in
Dr.
ideal
Bagri?
world, yes,
But
IGRA.
IGRA is now, as per under RNTCP program, now it is free. It's
Is
free
it
in
free?
Kerala.
Sorry, I was not aware about this information. I'm sorry.
It's free in Kerala. So we are doing IGRA only.
Then,
And you can't depend on the mandatory test also.
then it's good. Then it's great.
Dr. Bagri, एक चीज I would like to say here is that MAN2 can be falsely positive in inflammatory disorders. So what the protocol we use in our clinic is that Dr. Mahato sir is in charge of our clinic, and what he has proposed is that we do IGRA as well, because there are multiple publications from Indian authors also, and because you cannot rule out. So IGRA, MON2, both should be negative before you venture on giving biologicals, because tuberculosis incidence is quite high in India. Although using the protocol that we did, like I mentioned in my presentation also, we have not seen even a single incidence of reactivation of TB in the last 6 years that we've been using biologicals, and we've been using it quite liberally, I must say. So IGRA should be done. Matlab MON2 alone would not be sufficient.
And also, X-ray test is quite cheap as compared to IGRA. We should be doing X-ray test in all the
So
places.
that we anyways do. We are doing X-ray test regularly. That
Yeah.
has to be done. Yes,
If I am
yes.
not mistaken, I believe the cost is 3,000 only. IGRA.
So
IGRA.
2,300 in
Yeah,
lung,
something like that.
pathology, and other
2000, something
centers.
around 2000.
No, in that case, if the MAN2 is falsely positive and IGRA is negative,
Yeah, what do you do?
I'll tell you what we do, sir. Hanji, मैं बताती हूँ.
withholding biological in that patient,
No,
because
we don't withhold, sir. If either of them is positive, either MON2 is positive or the IGRA is positive, and the chest X-ray is normal, the child does not have evidence of active TB, what we do is we use 3HR, that is 3 months of INH and rifampicin, and 1 month after that, and 1 month later we start with biological. This is how we are treating latent TB, and we've got wonderful results. Of course, if there is active TB, you treat like your RNTCP protocol and begin biologicals only after 3 months of giving ATT. So biologicals would get delayed by 1 month if it is a latent TB. Active TB, you must wait for at least 3 months therapy as per the RNTCP. And we must screen very, very rigorously, so especially MAN2, IGRA, and chest X-ray before we venture even on tofacitinib. There are a lot of pediatrician friends who keep asking, why do we need to screen for latent TB when we are starting small biologicals, small molecules like JAK inhibitors? So, but even in that, we must screen for latent TB and treat for latent TB before we start with small biologicals like JAK inhibitors as well.
Yeah.
Dr. Bagri, you
Am I right?
that IGRA versus MAN2, MAN2 is positive, IGRA is negative. You'll also go with the same protocol.
Yes, sir. We
Yeah,
will. Yes, sir. We will give ATT for three. ATT means 3HR.
Cephalexin.
We will not give the complete ATT. We will give 3HR, and 1 month later we will start with the biological. Protocol has worked well for us, and we've done a lot of research, especially the senior, मेरे जो senior है, Dr. Mahato sir, who's in charge of our clinic, and we have decided that this works well for us.
So in that regard, can I just make, I think
Yeah,
this is an
please.
important point. So I mean, if MON2 is positive, irrespective of IGRA, so that is what I was trying to say, that the cost curtailing. So if you do chest X-ray, which is normal, if you do MON2 positivity, anyway, irrespective of IGRA is positive or not, you are going to start prophylaxis. So why to spend give extra expense of 2,300? I
So
agree
if
with
you
this.
do the test, both are negative, then go for it.
So, but yes, as Dr. Anu is saying, if MON2 is negative, then of course, to be doubly sure, you go ahead with IGRA. And if it is positive, just start,
Yeah.
Philex.
It's a very
Yes.
tricky waters, to
Yeah.
yeah, it's quite tricky, sir.
Retrospectively thinking, would you say that acute rheumatic fever of olden days was GIA?
So, absolutely. I would. I
What's
would.
the question? Acute rheumatic fever.
Yeah.
Honestly speaking, it has been a long that I've seen acute rheumatic fever. And yes,
It isn't.
in
Yeah.
fact, but I won't hesitate to say that many, as I have shown in the last case with who underwent the cardiac replacement, he was actually getting benzythine penicillin every 21 days very religiously to ensure that he is debilitated on bed and also that his wall gets replaced because he was actually having ERA or spondyloarthritis. So the acute rheumatic fever probably has declined to a drastic stage.
Yes.
And usually it's migratory arthritis, short lasting, that doesn't have deforming or
Yes.
uh, uh, destructive arthritis as we see in inflammatory arthritis like GI.
I think Dr. Bagri, you've
So,
nailed
Dr. Pankaj, your final comments?
Yeah.
So I think before we conclude, one or two more issues which I wanted to discuss. As you said yourself, that ultimately it's a clinical diagnosis.
Yes.
And as a physician, as a pediatrician, we have been told so many times in our medical colleges anything can be tuberculosis. I think looking at all the cases which you showed, it comes to my mind because the most of the physicians practicing, they always look for tuberculosis. They get any clue, fever, weight loss, single joint involvement, MEN2 positive, they will start ATD. ERA does not come into their mind till the time he gets uveitis. Then definitely somebody can point out that yes. So if they do HLA B27 at that stage, if that message can be done, that if it is a, even if you're suspecting tuberculosis by this scenario, you do HLA B27, it is negative, it's all right, you may still consider this. If it is positive, reconsider your thought, maybe take a second opinion, refer to a pediatric rheumatologist before you start ATD, something like that. Because I was just thinking that how can you spread this message
Okay.
that
So
we have done enough for
got it.
tuberculosis?
Very important question. So let me try to make it simple. So first of all, tubercular arthritis, let's look at it. Tubercular arthritis usually is monoarticular arthritis. Number one. Number two, the extent of damage. Here is the role of imaging. If monoarticular arthritis, I would say, apart from clinical assessment and the ancillary evidence of tuberculosis, you have to search for, which includes significant fever, significant weight loss, history of contact, and others. And apart from that, if you do X-ray or an MRI, that will show a dirty joint destruction, if and periosteitis, osteomyelitis, collections, that would be in favor of tubercular arthritis. In contrast to the inflammatory arthritis, where there would be mainly smooth synovial effusion without any collection, that would favor inflammatory arthritis. This is one thing that you need to do an MRI and need to discuss this with radiologists. Number two, the second type of arthritis that often encountered in tuberculosis or described with tuberculosis is Ponson's arthritis. This is what is known as reactive arthritis, where these patients have a focus of tuberculosis. For example, someone is having chest tuberculosis and has reactive arthritis in form of multiple arthritis, which again can be small joint involvement, but you have a focus of tuberculosis somewhere. So this is reactive arthritis. So these are two sorts of arthritis which are documented with tuberculosis. Coming to the ERA or spondyloarthropathy that we have discussed, yes, as I told, age, number one, age, somewhere around 7 to 8 years of age or above, adolescent boy, chiefly boy, infradiaphragmatic joint involvement, typically knee or hip joint involvement, or low back pain. Along with, you have to actively ask for the history of enthesitis, which means heel pain, the tenderness at the sites which I have shown in the diagram, would suggest towards an ERA. And on top of that, if HLA-B27 and inflammatory markers are positive, probably we are dealing with a child with ERA. rather than tuberculosis.
One more point, if you'll allow me. Sorry for my voice.
Yeah, sure. Please, Dr. Neha.
Yeah, so in a lot of cases, still the doubt remains. So it would be a good idea to go for synovial biopsy or even a joint aspiration and send it for gene expert.
It's controversial.
The yield for it is very, very less. But yes, as rightly pointed out, this can be considered in some doubtful cases, particularly which are monoarticular arthritis.
Sir, another thing that before we label as monoarticular, we have seen many times that ankle arthritis, Dr. Bagri, I think Dr. Neha will also agree with me that ankle arthritis is often missed in pediatric population. And when they come to us with monoarticular arthritis and when we go to examine these children, we note that they have ankle arthritis as well. So before you're saying monoarticular, let's be doubly sure that it is actually monoarticular, because ankle arthritis is quite often missed, because we teach our PGs, okay, you don't only have to look from the front, you also have to look from the back, because like Dr. Bagri showed a beautiful picture of a tendo Achilles swelling, right? So
Yeah.
even that can be missed if you just look at the joint uh, in from the frontal view itself. So be very, very careful before you say it is a monoarticular disease. Examine all the joints, and we have a homunculus, which I think we are all well aware of, and we should see all the joints.
And the other point, right, is at times you can also, if you ask carefully, there could be a history of other joint involvement sometime back in the past. So that will again help connecting the dots and ensure that this is an inflammatory arthritis.
And the other thing is that even if you are diagnosing ERA, they are on some management. Is the management going to be lifelong? Will they ever come out of this disorder? They will use lifelong drugs.
That's a good question. No clear answer though. But yes, in simplified way, usually these patients would respond, 50% or so would respond well. It depends on host of factors, how significant is the sacroiliitis, how significant are the inflammatory markers. But usually they do well. And if the disease is controlled for at least a year or so on the biological DMARDs or the DMARDs, then we may consider stopping or tapering the drugs. I am more in favor of stopping the drugs. But after stopping, a fair chunk, around 50 per 3/4, can again have a relapse of the disease during their adulthood. But yes, the key is we have to treat the disease so that the lifelong disability can be prevented.
Right. And another question which comes to my mind is that if you diagnose a patient of HLA-B27 positive ERA and a sibling, a male sibling, adolescent male sibling is coming to you for a pediatric follow-up, is it a point getting HLA-B27 in that asymptomatic sibling and screen them at some point of time, 9, 10 years, 15 years, and say that, okay, you can do something better before they clinically manifest?
Okay, so this is a very good question. All the SIBs of or this, that is why the family history of ankylosing spondylitis is one of the criteria while we diagnose someone as ERA, because these patients have high folds of having ERA or as ankylosing spondylitis if there is a family affected. But in an asymptomatic child, I don't think there is a need of doing HLA-B27. But yes, if they are symptomatic at any point in time, the threshold should be low for diagnosing ERA, because they have high chances for sure.
So
But
asymptomatic, there is nothing you can do about it. You
yeah, we
cannot change
can't
the
do.
course of the
Yes,
disease.
because as I told, 6 to 8% of the normal population can also have HLA-B27. That will probably increase the mental burden of the patient on the child and the family.
Another message which was given in the first talk also, that the method which HLA-B27 is done, PCR, also has to emphasize, because we have seen a lot of false negative by the
Yeah,
by the cheaper methods of HLA-B27, and then all the diagnosis gets for a toss because you have documented a B27 negative or something. So I think thank you so much, all. It was a great discussion, and I liked your way of presentation. It stimulated each one of us to contribute, whether it was Dr. Manish, Dr. Bennett, myself, Dr. Ajay, into the discussion. So we had to keep our ears and eyes open because the question could pop off any point of time. So it is a good way to keep the audience awake, and you are a good, great orator, and definitely all of us have learned from you, and we'll be uploading this. And thank you so much, Dr. Bennett, Dr. Manish,
Thank you,
Dr.
sir.
Anu.
But before you close,
Thank you very much.
Yeah.
Yes, sir.
Before you close, I just want an appeal.
Yeah.
Appeal to the President and Dr. Ajay both. Since
Yeah.
March, I had
Yes, sir.
discussed with Ajay this. 18th March is celebrated as World Young Rheumatic Disease Day. And in capacity of your chair, Dr. Pankaj, I would request you to do something to spread the message more widely.
18th
I have
March.
already Pankaj
Yeah.
to do something on 16th March. 16th March, we are having a run at Nehru Park.
So what
What
we
We'll have
can
a
do is
banner.
that we can also make some, Dr.
Banner.
Narendra, first of all, you're invited to our runathon, which is going to happen at Nehru Park. So
Yeah.
we will be spreading that message to not only pediatricians, but even the people at large that, yes, we have to do something on that.
Dr. Anu, what do you think?
Yeah. And before we close, we also have a request to make that we have our annual conference, Pediatric Conference of North India. You can see the banner now. It is going to happen at Lee Meridian on 30th and 31st of August. And I request all of you to register for that also. And also request your friends, colleagues to come forward for registration. And even Dr. Ajay has a comment to make. Dr. Ajay.
Thank you, Dr. Pankaj. We have a North India Pediatric Infectious Disease Conference also, and we'll have some session related to infection mimics in that. And I request all of you to please register. And we are thankful to Dr. Narendra, Dr. Anu, and Dr. Neha, and Dr. Chandra joining in, and all the delegates who wake up early in the morning to attend this session. We are really thankful to Dr. Bennett and Dr. Manish.
Okay, thank you so much, and
Thank you.
please
Wonderful,
join us
Dr.
again next week, Monday, 9
And sir,
o'clock.
one more thing.
Yeah,
Yeah,
please.
one more thing. So, whenever we talk about tuberculosis, government has given very good NTP guidelines along with IAP. Just strictly follow that guidelines, because in near future it's going to be medical legal if you start AKT in a patient who has some different diagnosis. And nowadays AKT are not easily available in routine medical stores, so they are going to be available from government only, in urban health centers only. So please refer to them if you have any doubt, but don't start AKT in hurriedly. It will not, if you delay the diagnosis of tuberculosis by a few weeks, it is not going to do much damage. But please don't be in hurry to start AKT. That is the main message for NTEP.
Yeah, thank you so much. That's a great message.
So, Sushil, please close the session. Thank you very much.
Thank
Please
you.
join Sunday.
Enjoy your Sunday with your family. Thank you.
Thank you. Thank you.